And there we go. So before we get started, I would like to thank our conference sponsors, the Yale School of Public Health, the Connecticut Department of Public Health, the UConn Program in Applied Public Health Sciences, and the University of New Haven. Also, I would like to thank our session sponsors, so the University of St. Joseph and the University of Hartford College of Education, Nursing, and Health Professions. For those who are seeking CHES or MCHES credits, the session has been approved for one Category 1 credit, and the application for that credit is available on CPHA's website. Today we have 3 wonderful presentations to share with you. First, we are going to be hearing from Megan Lubner. Megan is a third-year medical student at the Frank Netter School of Medicine. She graduated summa cum laude from Brandeis University in 2018. Her special topics of interest include street medicine, addiction treatment, and harm reduction. After that, we are going to hear from Deborah List and possibly some portion of her research team. Deborah is the co-principal investigator on the food emergency distribution during COVID-19 project at the Center for Social Policy at Fairfield University. She teaches public health at the University of New Haven and is principal at College Access and Beyond LLC. Finally, we're going to hear from Veronica Schmidt. Veronica is a 2022 MD-MPH candidate at the University of Connecticut School of Medicine. She is an AHEC Urban Service Scholar, co-founder of the Latino Medical Student Association chapter, and a new environmental health group called Sustainability at UConn. Just so you guys know, we're going to save all of the Q&A until after all of our presenters have gone today, so please put your questions in the chat box. I don't have the technical ability to unmute any of you, so the questions that you have do have to go in the chat box. With that, let's get started. Megan?
All right, so let me go ahead and share my screen here. Oh, it says host disabled participant screen sharing.
That is not ideal. Okay, then let's do it the other way. I'm going to pull up your slides and
it should be the one with the blue background, the one I just emailed to you, just so it's at the top.
So I'm gonna, okay, just email to me. I don't have.
Oh no,
so I think we're going to have to make this work with one that I have loaded. I apologize.
Okay.
All right, so there we go. And Megan, if you just want to give a shout when you're ready for me to advance a slide.
Sure, yeah, you can go ahead and I don't know if you want to make it full, or that's fine. I don't know if it's like, there we go, perfect. Okay, so hi everybody, my name is Megan, and the title of my project is the Health Needs Assessment of Unhoused and Marginally Housed People During COVID-19 in New Haven, Connecticut. My mentor, Tracy Van Ost, is on the call today. So shout out to Tracy. Thank you for all of your help and everything you do. So, all right, let's just jump into it. So Elizabeth, next slide, please. So just a brief outline. Today I'm going to talk about the background, kind of like where we all were at the beginning of 2019, what was happening with this population at that time, right when COVID hit. Then I'll jump right into the study design, what exactly was done. We'll go over some findings, and then I'll talk about some future directions. So go ahead and next slide, please. Next slide. All right, so I think it's important just to quickly remind ourselves like where we were. So in March of 2020, there were about 2,009 people staying in shelters in Connecticut, and an additional 2,904 people were counted during the annual count in time. And these people were considered to be completely unsheltered. And so these are people who are either living in like the street or in other places not intended for human habitation, such as under like overpasses and things of that nature. So that's about 4,000 people who are, well, more than that, almost 5,000 people who are either like severely unstably housed or like marginally housed or just straight out unsheltered. Um, and so we're kind of starting out from a pretty precarious point, and then suddenly COVID hits, which is really being in a homeless shelter is probably one of the worst places you could be during a viral pandemic that spreads through the air. And so we had to act really fast. Next slide, please. And so this is stopping some of those risks. This population, which we'll get to more through the data that we showed, but it's pretty well accepted in the literature that they are sicker on average, have high rates of comorbid health conditions. And then on top of that, just like being in a homeless shelter where it's commonly open air, you're sharing a space with many people, it's pretty much impossible to maintain social distancing guidelines, as we were all told. You don't really have a safe place to shelter in place, as we were all told. So moving on to the next slide, please. Okay, so what happened? We actually, next slide. Governor Lamont put through an emergency executive order called Authorization to Provide for Non-Congregate Housing for Persons at Risk. And so this provided funding that catalyzed a large-scale effort to decompress shelters. So homeless shelter clients were rapidly moved into hotels and apartments. And I actually just recently, this was put out, I believe, on October 1st. The hotels are to remain open until at least February of 2022. So, and FEMA funding has been extended until that time too, which is really quite excellent. And so one of the main ramifications of this is that that people were placed not only into hotels, but also into semi-permanent and like supportive housing. So things like empty apartments and houses were made available. At one of the organizations I partnered with for this project, over 580 people have been housed in permanent supportive housing since the pandemic started. So one silver lining to the pandemic, you could say, for sure. Next slide, please. All right, jumping into the study design. So we have a mixed methods survey interview that was done in New Haven by 4 medical students, including myself. It was a pretty robust survey tool. So we're talking like a 40 close-ended multiple choice questions, and then the interview portion, which was open-ended. The entirety of the interview was recorded. It ranged on average from like 15 minutes to as much as like 1 hour. Most people really spoke for about 20 minutes, but and we interviewed 114 people. So this is like a pretty monstrous data set. And it's very exciting though, because this population has been historically undersampled, and we tend to not get like the same level of granular detail that we do with other surveys from different populations. So that created some very exciting data that I'm looking forward to sharing with you all. Go into the next slide, please. So a little bit more context. The inclusion criteria, you did have to be 18 years old and English speaking for the first part of the survey. I recognize that does exclude a large portion of our population, especially in New Haven, and that is a future direction, which I'll speak to at the end. We also had to ensure that people had the capacity to consent. This was brought up in our IRB review, and so how we ensured this is we would just quiz them gently, like, could you recap for me what the risks and benefits of participating are, just to kind of give the interviewers time to gauge that. And then they also needed to either be currently unhoused, previously unhoused, or unstably housed, which we have clear definitions of from HUD, or it's Housing and Urban Development. And then participants were given a $10 Dunkin' Donuts gift card for participation. There was no cutoff. Like we told people to take a minimum of 10 minutes, which some people did, or a maximum of however long they wanted to talk to us for. And that ended up giving us some pretty interesting results. And then in order to actually access this population, we partnered with 5 local nonprofits in New Haven, so that tend to serve this population. So that includes soup kitchens, homeless shelters, et cetera. And then we would recruit and advertise. And people really seem to like it. So that was kind of a nice, I was like, who's going to want to do this long survey? But it turns out a lot of people wanted to do this long survey. And they were excited to talk about kind of like themselves and their experience. And it was very elucidating. So we interviewed 114 and our goal was a minimum of 100. So we met that goal. We'll move on to the next slide, please. And that brings us to our findings. So first, I just want to talk about the makeup of this population. So we'll go on to the next slide where we talk about demographics. So the average age of our participants was about 50 years old, plus or minus 11 and a half years. As we see that it's about 46% white, 25% Black, and 26% Hispanic, and then 3% who identified as other. These are all self-identified. Gender, we had way more men than women. So we had 75% men, 25% women, and then very few veterans. And then we'll go on to the next slide here. For socioeconomics, we had a very overrepresentation compared to our general population of people who had achieved a maximum of a high school education. Although a surprising amount did also achieve some college. Many people said that they dropped out due to like life circumstances. And this was another reason that we recorded the entirety of the interview, is like we wanted to capture some of the nuance of people's experience that couldn't be represented sufficiently through something like a closed-ended survey. Very few people were able to currently work. But something that I thought was particularly interesting is that over 90% did have health insurance, almost entirely either Medicare or Medicaid. So we'll go on to the next slide. So looking at housing status patterns, this was a portion of the survey that during our pilot, I had to revise so many times because housing information becomes very complicated when you have a pretty unstable life and no reliable place to live and go. So while we had 70% of our respondents were currently homeless, the other 68% had also previously been homeless. And typically how this works is you have like an episode of homelessness, and how you define that is where it gets tricky, because if you, according to the federal government, if you crash with a friend, you're no longer homeless. But is that true in terms of like a functional sense of like having a stable place to live and go to every night and a warm place to sleep that's safe and reliable? I would say no, as like a public health person. But we're looking, another thing that I thought was interesting is that people who we interviewed also tend to be homeless for a really long period of time. So on average, it was about like 5 years and some change, like throughout their lifetime. Again, most of these people were about 50 years old. So that's a significant portion of people's lives. And then of the people who had been homeless up until the survey for like one continuous episode, it had been just under 5 years. So significantly long over time, and then also like a cumulative long amount, as well as a long period in between having stable places to live. So go ahead and we'll go on to the next slide here. And then just to kind of like illustrate what this might mean, we asked a question we actually borrowed from HUD's point in time count, which is, for those of you who might not be familiar, it's where once a year, every major city in the United States that receives any funding from the federal government through HUD, we are required to do what's called a point in time count, where you have volunteers canvass the city during usually one of the coldest nights in the year and ask people a series of questions. And so I thought this was pretty interesting. It asks specifically, like, where are you sleeping tonight? And as we can see, we had like 28% of participants were able to have access to a house or apartment. But then we have a lot of folks who are currently either living on like the street or sidewalk, woods or outdoor encampment, transitional housing, emergency shelters, and other things of that nature. Another thing I also wanted to point out on this slide is that a large portion of the people we were interviewing during COVID were staying in a motel or a hotel that was paid for by a homeless agency. And so they would be considered not homeless at this time. but many people were very concerned about what would happen should funding run out and the hotels close. And that was a constant source of stress. All right, next slide, please. So now we want to dig into like a little bit more like the health status. And so we just have some like general markers here. So we have BMI, which I know is like nobody's like favorite tool as a marker of health, but it's what we have right now. Most people actually tend to have a normal BMI. A few people were underweight, and many people were overweight or obese. Interestingly, in New Haven, a large portion of folks had a primary care provider. Something that comes up in the qualitative portion of the data when you listen to the recordings is that pretty much everybody was going to a community health center. And so they have a couple street medicine teams in New Haven that specifically work with this population. So that was interesting. Next slide, please. Then we just asked kind of like a laundry list to try to get an idea what kind of medical conditions we're seeing in this population. As you can see, mental health conditions and addiction and substance use disorders are very overrepresented. We also saw a really high degree of physical disability, learning disabilities, and traumatic brain injuries. And the way this is phrased, I think, is important because it's like, have you ever been diagnosed? This population, as we'll get to in a minute, tends to underuse resources like primary care settings. It tends to overuse settings like emergency departments. And so I think it's interesting that despite that, like we still see people who know, like have had an interaction with a healthcare provider and we're told that they have these conditions, such as a traumatic brain injury. I mean, 20%, that's astronomical. So just wanted to highlight that here. I'll go on to the next slide.
Go into the next slide, just a 3-minute warning for you though.
Okay, yeah, that's fine. Okay, getting to the last portion of the data here. So we wanted to get an idea of kind of like what services are people using. And we have on here like services that are not necessarily just healthcare. We thought this was important in a pilot portion of the study. We had excluded things like soup kitchens and stuff, and we're only asking about, like how many times you go to the doctor. But the data we were collecting was just honestly just not that useful, because people don't really go to the doctor and like in a regular kind of way if they are currently unhoused. And I think one of the more interesting aspects that at least that I learned from this project is that being homeless is a full-time job. Is actually what a couple of people have mentioned, and it was a robust trend. So we had to ask about what else are they doing, right? And so other health behaviors would be things like going to soup kitchens, food pantries, seeking care in emergency room. We see half of them had been to the ED in the past 6 months alone, and other things of that nature. And so we'll keep going on. Next slide. I know we got to wrap up soon. Yeah, so just moving on to future directions, I just wanted to provide a glimpse of the data. I mean, it goes on and on and on of more things of this trends. But like I mentioned before, unfortunately, one of the criteria was that they had to be English speaking. My Spanish is just not adequate to provide an equitable experience of that. But we have recruited 2 individuals who want to make this part of their capstone project for their graduation requirement who are fluent. And so we're looking to expand this in the coming months. Ultimately, I'd love to develop a validated health assessment survey tool, and then also continue to analyze this data and submit a manuscript ultimately. And that is what I was able to capture in this short period of time. Thank you so much.
Wonderful. Thank you so much, Megan. We are, yes, clapping as Tracy is doing. Deborah, I am turning it over to you. You should now be able to share your screen, I've been told by our tech support. So.
Okay, looks like, can you all see that?
Yes.
Okay. And Melissa and Mehmet should be able to speak with me. Can they be unmuted?
We can try.
It worked.
It worked. Okay.
Okay, perfect. Excellent. Looks like our technology issues are slowly fading. Excellent. Okay, so our research group is going to present on the COVID-19 impact on food pantries, a qualitative analysis. So very connected to some of what we just heard as we were discussing in the practice session. And so I just wanted to begin by introducing my two colleagues that are going to be presenting with me. Melissa Kwan is the director of the Center for Social Impact at Fairfield University, and Mehmet Kansoy is an assistant professor in the sociology and anthropology departments in the College of Arts and Sciences at Fairfield University. Other members of our research team, Anya Axon and Jonathan Delgado, couldn't be with us, but were very important members of our research team. So certainly want to acknowledge them and their contributions. The objectives for this presentation are to describe the impact of COVID on food access in the Norwalk and Bridgeport areas. Those were the food pantries that we were able to speak with. To explore the system issues that food pantries experienced related to access, distribution, and communication during the pandemic. And we'll start to discuss the policy level change and how that can improve community food access. That's the next level of our project. Just to review the sort of overview of this project, some of you may have been able to be at a presentation at CPHA in the fall of 2019, envisioning a holistic food pantry, a collaborative approach that was presented by Dr. Sally Gerard and myself. And that was on the first phase of this project. This original project was supported by 3 CDC AACN Public Population Learning Hub grants that Dr. Gerard and I received. And we pivoted this work a little bit. The original goal was to create a collaborative of shared resources for holistic approaches to food pantries. And our primary partner that continued to be our partner on this work was the Council of Churches of Greater Bridgeport. When COVID-19 hit, the sort of collaborative partners came together and really began to examine how the impact of the pandemic was affecting the holistic need for food pantries. And we pivoted a little bit of our research and our focus, as well as moving the project to be housed into the Center for Social Impact at Fairfield University, since a lot of the goals of the project aligned with the goals of the Center for Social Impact. Our study design was semi-structured interviews with 15 food pantry managers, as I mentioned, in the Norwalk and Bridgeport area. These were identified by members of our collaborative research team, and most of those were identified either through the Council of Churches, the Hunger Outreach Network, or through the Norwalk Health Department. And we used inductive analysis to identify themes from the data. So all of our data was coded using Deduce, and we went through it with all of our members of our research team. And then we were able to develop themes from that, which we'll be discussing with you throughout the presentation. And we shared these results with the pantry managers and the Hunger Outreach Network for participant comments and feedback. One of the things that was highlighted for us in the conference that we originally held in the first presentation we gave was that the information on these issues that food pantries have experienced in recent years is there's lots of information and data and feedback that the pantry managers and the patrons themselves have, and it hasn't been shared widely amongst each other or amongst sort of the various researchers and teams that have come in throughout the years and looked at the information being collected in the food pantries. So that was identified very early on in this project in the early stages 3 years ago. And so we really committed to making sure that we gave feedback to those who had participated in this project, both the larger sort of collaborative members, but also the food pantry managers themselves. Okay. The original sort of overview of what we saw was a significant strain on the system, and we saw quite a bit of feedback on this from those that we interviewed. We saw that the pantries themselves throughout all of the different ones that we interviewed, and this was something that you probably all saw within the media. You know, you couldn't turn on CNN or anything sort of during the pandemic without seeing lines at food pantries, lines for distribution of food. So there's an increased number of patrons, and we certainly wanted to understand what that meant in terms of distribution of food. Also new types of patrons. So we saw throughout the information that we were getting that we were seeing patrons at food pantries that were coming from a wider distance, from much farther away, patrons that had never used food pantries before, families that were showing up that had never needed food before and were looking for new resources for food. Patrons that actually would use multiple food pantries in terms of accessing food that had never needed to do that before. Another strain that was on the system was the COVID-19 restrictions. And we learned a lot from the pantry managers about their frustrations and challenges with trying to access understandings of the protocol. And I think that a lot of that came from simply the entire system sort of struggling with what those protocols were, what they meant, as all of us were sort of learning in public health as the pandemic came about, all of what that meant, issues around masking, issues around vaccination. But as they were dealing with food and food access, it became very complicated in terms of what the volunteers needed to do, what the staff needed to do, what the patrons needed to do. And so that placed a lot of confusion on the system and how best to serve the needs of the patrons, as well as serve the needs of the staff and the volunteers. And that was something that we repeatedly heard about in terms of how to best protect those that were providing the food and what were the best protocols to put into place. And then finally, obviously an issue on supply disruption, something that we're still seeing significantly in terms of supply chain issues, but specifically around food became an issue that affected both the quantity and quality in terms of what the food access was. And so that's something that we'll talk about more specifically in terms of how that affected what type of food was able to be provided to the patrons, how the food was distributed, and changes also in the structure of the way food was delivered. So as was noted previously in the presentation, many people who access food pantries also were reliant on soup kitchens. One of the things that we heard a lot about was that many food pantries that had been connected to things like soup kitchens no longer had that in place. So when soup kitchens closed down, or when community centers that would provide things like a weekly meal were no longer able to provide that, it changed the entire structure of how food was distributed. So that changed both the distribution, but also that community sense in terms of how food was distributed. Okay, so there were two sort of major themes that several major themes that we saw that repeated throughout the emergency food system issues. The first was that the emergency food system in Norwalk and Bridgeport was marked by sort of these lack of planning, coordination, and clarity about policy. And that's some of what I just mentioned, but we heard that over and over again, and we're going to talk about that a little bit more specifically. And that came about because I really think that when we talk about sort of preparedness, and those of you that have worked in the preparedness field in public health can attest to this, no one really thought about sort of these long-term planning issues. And one of the things that we heard frequently was that meetings never occurred in terms of planning that discussed food access and food security. So when people were thinking about long-term planning and thinking about preparedness and thinking about emergencies, rarely was there inclusion of conversations around food in coordination with some of these other services. So the coordination of services became complicated because food wasn't included in those conversations. And so suddenly when buildings were shut down or access to services were shut down, there was a lack of coordination of how people thought about how they were going to connect to food. And suddenly you had months and months of people needing to access food, and that hadn't been clearly thought about. And then, of course, the policy issues. What was going to happen in terms of food access, the protocols for COVID, what was the policy in terms of food distribution, who was responsible for food distribution, at what level was the food distribution responsibility an issue? And that becomes sort of the long-term policy questions that we'll be asking in terms of who was responsible for it. Was it at the local level, the state level, the federal level? Was it FEMA? Was it FDA? Where did the buck stop? And we are trying to further investigate some of that. On the other hand, some of the stopgap measures created at the beginning of the pandemic process to address these problems, while not sustainable long-term, were really quite creative. So reducing food quality, especially with regard to protein and dairy and variety, while they worked to meet the need and to provide food in sort of an emergent situation, are not something we want to see long-term. We really had had great progress in how we see food distribution in food pantries in terms of patron choice and making sure we're meeting all of the health and protein needs of patrons. And so moving to a more of an emergency sort of let's just provide whatever food we have, while that was fine sort of for an emergency situation, it's not something we want to see long term. And those changing distribution models in terms of using things like food trucks, we did lose patron choice. And so again, that's something that we worked long and hard to see, and we don't want to necessarily lose that. So I think we need to think more creatively in terms of what we'll do in emergencies in the future, and to ensure that we have patron choice, making sure, you know, for circumstances where the young children and families, specific food needs, allergens, things like that, all of that sort of got put to the wayside when we no longer had had patron choice.
Yeah. I lost track of which slide we were on. So I'm going to talk a bit more about the types of issues that Deb listed already that marked the pandemic experience in the Norwalk Bridgeport area. So, and the first thing that's notable is the problems of the system as a whole, and the fact that not many people thought of it as a system as a whole. So we saw things like what this quote is showing you, where like people on the ground responding to the food emergencies and the increased like frequency, the different types of needs that they were experiencing, didn't have clarity on like what was going on, who was responsible for what, where the next shipment of food was coming from. So this ended up being a huge hurdle that like it came up in basically every interview that we did. Deb, do you mind advancing to the next slide? But the three big like teams in terms of responses to the pandemic that emerged were these like the stopgap measures that food pantry managers on the ground had to put in place, the reduction in food quality that they experienced and that they really cared about. Again, as Deb mentioned earlier, this was a huge concern for everyone. And ultimately, the distribution model changes, partly as a result of the COVID restrictions, partly as a result of the supply chain disruptions that like a vast majority of managers felt very uncomfortable with, because they had to go back to a system that they saw as inferior, that they saw as not very responsive to the actual needs of the populations that they were serving. Deb, do you mind advancing? So in terms of stopgap measures, we saw a lot of them. You're seeing one example of it here, which was about food rescues from large grocery stores. A lot of people decided to volunteer their time and resources to do this type of stuff. And while it was useful, it wasn't as useful as the supply chain disruptions that this was trying to replace. So people brought in more groceries, like more food in, but not all of it was usable, not all of it was redistributable. So this ended up creating, this ended up offering a greater supply of food, but usually not in a way that was sustainable in the long run. Many of the managers talked about these issues, saying like they would have one-off or like periodical partnerships and stopgap measures that ended up not working out in the long run. Deb, do you mind moving to next? The second thing here is, because of all of these stopgap measures and disruptions to the supply chain, all of the managers talked about some reductions in their food quality, the quality of the foods that they were offering. The biggest hits were, of course, in like fresh produce and like meats and other proteins, because again, the traditional ways that they used to supply these things, for example, getting them from grocery stores or getting them from the food bank, ended up usually not working out very well, because these larger suppliers were having their own issues, especially in the first year of the pandemic. And this ended up meaning that in many cases, the pantries were not able to offer food that was as high a quality as they wanted to, or they felt like they were able to before the pandemic. Deb, do you mind going to the next one? And the ultimate result of both of these, both the disruptions and the reduction of quality, was a loss of patron choice. Many pantries felt like especially because of like occupancy restrictions or because of things like uh, like social distancing requirements. They could no longer offer patron choice. Almost all of them went to pre-packed bags and boxes and stuff like that. Some of them had to distribute them outside, like for a long period of the first year. So patron choice kind of went away. Usually, all pantries did things around the edges, like you see in this quotation, where they would give patrons some choice, like a couple of items here and there, but the vast majority of the food they distributed went back to a prepackaged model.
All right, Melissa's going to take us through what worked.
Mhm.
I just want to say this is a sort of 3-ish, 2-ish minute warning for you guys. I apologize.
Problem. I think we can make it. So in terms of what worked, the managers were very proud of their ability to stay open and their own kind of ability to innovate by connecting with one another. We certainly found that pantries that had access to more space, to things like refrigerators, and to discretionary money that enabled them to purchase foods that they weren't able to readily get from food banks and other sources, those pantries were more resilient, whereas others that were completely reliant on the food pantry had a more difficult time, or who had less space to store food, were less resilient during the pandemic. And in terms of, they talked about really benefiting from community connectors. So people within our organizations within the community that were able to do some level of coordination and to facilitate communication among the pantries, that was really helpful. The ability to move food from space to space. Again, this kind of was access to resources. So pantries that had access to vans they were able to kind of participate in the food box programs, building again the resiliency. Other community connectors that were able to facilitate information sharing. They were able to kind of move food from spaces where there was excess to spaces where there was less, and just generally able to share out information about policy changes and public health situations. So I think probably we should skip ahead, Deb, to maybe just the report page.
Sure.
So we do have a report that is forthcoming, probably within a week or so. And if you visit this Fairfield University Center for Social Impact website, you'll be able to download the full report. And as Deborah said, we intend to distribute this to all those that participated, to all the food pantries, so that they can use it for their own planning, their own advocacy, and their own policy recommendations.
And as we noted, our next phase of the project is to really go to some of the key policy level stakeholders and have conversations with them and sort of get a better handle on some of these conversations about what the policy level issues were and where improvements can go in the future in terms of preparing for other emergencies and talking about some of these issues around food access. Before we conclude, we just want to make sure that we acknowledge all of the support and help that we got, particularly from the pantry managers themselves who took time out. Many of them were actually sort of conducting business as we spoke with them. So that was really sort of impressive that they were able to take the time to meet with us. We did have 2 student interviewers involved in this project who were conducting the interviews with support of Fairfield University faculty. So we do want to acknowledge Morgan Dow and Michael Caruso, and they actually will be presenting from the student perspective of the project tomorrow during the poster presentation. So we encourage anyone to go and take a look at that, because we certainly always want to encourage our student work. And we do want to mention the collaborative members. This project would not have been possible without the support of all of the collaborative members. And I want to take a moment to note that one of our collaborative members is actually on this session. So we want to thank Gina Smith. But we did want to note that the Norwalk Health Department, the Council of Churches of Greater Bridgeport, St. Vincent's Medical Center, Yale New Haven Hospital, Feed My Sheep Food Pantry, and the Fairfield University School, Egan School of Nursing and Health Studies all had members that were participants of our larger collaborative and met regularly to review the entire process of what we were doing, talk to us about the survey instrument, and just keep us connected to the conversation. And so that we felt that we were connecting with all different members of the community and all different levels of interest in this project.
Great. Thank you so much for that. You did that at total auctioneer speed, so I applaud you for that, Deborah.
Not fast.
We don't have a lot of time for transition, so let us shift now to Veronica. Veronica, you are still on mute, but you can unmute yourself.
Unmute. Okay.
There you go.
And then we're sharing. Perfect. Hello, I'm Veronica, a medical student at the University of Connecticut and also a student of public health. Today I'll be presenting on the factors contributing to the adverse mental health symptoms of individuals who underwent COVID-19 testing and some policy implications. So the response of pandemics appropriately focuses on physical health. We think about treating and preventing illness and what we can do to prevent the spread of illness and disease. And I think before this COVID-19 pandemic, it was less well known or understood that pandemics and epidemics can have an impact on mental health. And the COVID-19 pandemic has resulted in many potential stressors that have affected mental health, such as loss of loved one, financial hardship, social isolation, disruptions in daily living. And there's even evidence to suggest that with a multitude of messages out there, especially with disinformation and misinformation, that has also impacted mental health as well.
So Veronica, just to interrupt, we could not see your screen, so I'm sharing your slides from my computer.
Oh no. Yeah.
So if you'd just like to tell me when you'd like me to advance them.
So let me see what you're sharing.
I'm sharing what you sent this morning.
Okay.
Okay.
So you're on the first. Okay, so you can flip ahead and go ahead another one. Okay. So the groups disproportionately. Oh, sorry. So since April 2020, late April 2020, the CDC has been doing a household pulse survey, which has assessed how COVID-19 is impacting the households across the country from both a social and an economic perspective. Data from the survey has demonstrated a greater than 3-time increase in the frequency of symptoms of depression and the symptoms of anxiety after the pandemic compared to 2019. And also different, and also this data from the study and other studies have also demonstrated that certain groups are disproportionately affected by adverse mental health symptoms. If you click again, don't click the box. That's going to take you. Nope.
My apologies. Let us try that again.
No worries. Don't click the actual pictures because they'll take you somewhere. Just click the box, like in the screen.
Okay.
Yeah.
Yep.
Okay. So yeah. So some studies have showed that women are at greater risk for having negative impact of mental health from the COVID-19 pandemic more than men, younger adults more than older adults. Click again. Click. And those who were impacted economically by this COVID-19 pandemic were also more likely to report symptoms of anxiety and depression. Click again. In certain ethnic and minority groups were more likely to report symptoms of anxiety or depression during the COVID-19 pandemic, such as Hispanics and Black African Americans. You can go ahead to the next slide. Okay, to provide some background for my study, in March of 2019, the Department of Public Health Sciences at the University of Connecticut created a survey which was used to assess the knowledge, attitudes, and beliefs of COVID-19 pandemic on individuals who lived in Connecticut. They were also interested in looking at the impact of COVID-19 on various populations, including Hispanics, homeless, disabled, and even medical students. Around the same time, providers at UConn Health began to test individuals for COVID-19. Most of these participants were referred to our testing site by their healthcare provider for a few reasons, mostly because they had symptoms of coronavirus. Some people also were due for a medical or a surgical procedure, and they wanted to have them test negative prior to having the procedure. Some people were to test negative prior to returning to employment. And then there was also voluntary testing of UConn Health employees to see what the positivity rate of UConn Health employees was. So I had this convenience sample available to me. And so I decided to look at what was the impact of the COVID-19 pandemic on this population. And over time, I became interested in understanding the mental health impact of COVID-19. So I sought to understand what was the frequency of the reported symptoms of depression, the symptoms of distress, and also what was the perceived increase in mental health symptoms during the pandemic in this population. I also sought to understand what factors were associated with reporting the symptoms of these different mental health outcomes. Go to the next slide, please. So I tailored the study that was originally put out by the Department of Public Health Sciences. And with the help of the Department of Infectious Diseases, I was able to distribute information about my survey study to everyone who came for testing for COVID-19 at the drive-through testing site in Farmington, Connecticut. So they were given information and instructed that they could go online to do an anonymous survey that was through Qualtrics. And I collected data from April to October of 2020. In the end, I decided to focus on non-healthcare workers. My rationale for this was that healthcare workers were going to have a unique experience for the COVID-19 pandemic. They were going to perhaps perceive risk of this pandemic differently due to their medical education. And also they were on the front lines of caring for individuals who were infected with COVID-19. So I decided to stick with the 232 non-healthcare workers who responded to my survey. Go to the next slide, please. And these are the mental health outcomes that I was interested in looking at. So I used the PHQ-2, which is a screening tool that's used by clinicians to assess for symptoms of depression. The Department of Public Health Sciences also created a distress scale to see if the participants were exhibiting symptoms of distress. They also, and the participants who said yes to any of these symptoms were then asked to compare these symptoms from before the pandemic to during the pandemic, and if they perceived an increase in mental health symptoms, or they said that these symptoms were occurring more than usual, that they were sought to have perceived increase in mental health symptoms. Next slide, please. And these are some of the factors that I was interested in assessing to see how, if they had an association with mental health. So I looked at demographics, I looked at health concerns specifically related to COVID-19, if they believed that they were going to test positive for the virus, or if they were referred because they had symptoms, behavioral changes that they may have made, specifically the behavioral changes that were recommended by the CDC in order to protect oneself and one's community and family from contracting the virus. If they were gathering resources in preparation for lockdowns or shutdown periods, and different attitudes that they may have had, such as long-term negative outcomes of the pandemic or long-term positive outcomes due to the pandemic. And then we also created a 15-item scale to look at the number of problems that were experienced during the shutdown or lockdown period. And these assessed what issues they may have had, specifically addressing the social impacts of the pandemic, such as not being able to visit or support older relatives or friends, unable to attend religious events or services or events, loneliness or boredom, addressed financial impacts of the pandemic, such as loss of income or loss of jobs, and other problems like problems with access to healthcare. Next slide, please. Here's some demographics for the non-healthcare worker survey respondents. They are mostly an older population above the age of 45, most identified as female, most identified as white, non-Hispanic. Again, they're mostly a fairly well-educated population, with most having at least 4 years of college under their belt, and most reported that they owned their home rather than rented. Next slide, please. Most of these individuals were employed full-time prior to the pandemic, and only 26% of them reported any loss of income during this pandemic. And this is consistent with some information that was collected from a survey in the Brookings Institute, which reported that 24% of respondents lost a job or income due to the COVID-19 pandemic. Next slide, please. So for the results, I found that in my survey population, only 11.6% of them had tested positive on the PHQ-2 or had symptoms of depression. 30.6% of them had symptoms of distress, and only 37.1% perceived an increase in mental health symptoms during the COVID-19 pandemic. I think in all, it's interesting, and this also suggests that the population that I surveyed may have been less impacted by the COVID-19 pandemic in terms of mental health. And the reason I say this is because when you compare this result to that of the household pulse survey, which collected information both at the state level and nationally, this is less than half that. So for example, in late April, early May, the symptoms of depression were reported at a frequency of 24.4% through the household pulse survey. And even nationally, it was 24.4% when you looked at early May data. And of course, this fluctuated over time, but according to the household pulse survey throughout 2020, symptoms of anxiety and depression, the frequency increased. You can go next slide, please. So in order to understand what factors were associated with the mental health outcomes that I was researching, I did a logistic regression analysis for each of these mental health outcomes. And with the help of some statisticians, I was able to create some models. And the factor that was associated with each of the mental health outcomes was the problems that were experienced during the shutdown or lockdown period. So for example, for every additional problem during the shutdown that respondents reported, the odds of having symptoms of depression increased by nearly 40%. Next slide, please. Another interesting finding was that rent versus home ownership was also associated with symptoms of depression or symptoms of distress. So one limitation of my study survey was that we did not ask for income. However, when I dug further, renting one's home has been associated with lower wealth. Therefore, this relationship of adverse mental health with renting may be reflective of the fact that lower income is associated with depression and distress. And this relationship may also have been exacerbated during this pandemic. Next slide, please. So health concerns related to having COVID-19 or knowing someone with COVID-19 or being referred to the testing center due to coronavirus symptoms was also associated with one of these mental health outcomes as well. Next slide. And next slide. And then again. Okay, great. So Respondents who identified as being Black or African American or Hispanic or Latino were nearly 7 times more likely to report increased mental health symptoms during the pandemic compared to white non-Hispanic respondents. And I think that this may be a reflection of the fact that the COVID-19 pandemic has brought social and racial injustice or inequity to the forefront. It is demonstrated that health equity is still not a reality, and COVID-19 has unequally affected many racial and ethnic minority groups, putting them more at risk of getting sick and dying from COVID-19. Black, African Americans, and Hispanic Latinos were definitely more likely to be infected, hospitalized, and have death from this COVID-19 pandemic. Next slide. And then the respondents who had symptoms of depression or who screened positive on the modified PHQ-2 were more likely to report having increased symptoms during the pandemic. Another limitation of my survey was we did not ask about pre-existing mental health conditions or symptoms. Therefore, it's unclear if the respondents had a pre-existing condition such as depression, but according to what was found in the literature, having a pre-existing mental health condition increased the risk of having adverse mental health symptoms during the pandemic. Next slide. So finally, there's been an unmet need in this country for mental health. A report that was published by the National Alliance on Mental Illness in 2017 observed that nearly half of the 60 million adults and children living with mental health conditions in the United States go without any treatment. During this pandemic, the increase in mental health symptoms combined with a shutdown resulted in challenges to access of healthcare services. And this has led to an exacerbation of the inadequacies of our mental health service system. Therefore, I think we need a population-based approach to mental health. And here are some ideas that have been found in the literature. We can continue the surveillance of mental health symptoms throughout the pandemic, and as it resolves, the pandemic will likely have long-lasting effects on mental health. And this continued surveillance will continue to inform us of how the population and nation may be responding to effects of this pandemic and different policies that we put into place. Also, addressing the risk factors that are exacerbated by the COVID-19 pandemic. So different financial concerns are a significant source of stress for adults, and past studies have demonstrated that interventions that promote financial and housing security improve population mental health. Also, mental health resources may need to be expanded to meet increased need. We've seen telepsychology become more popular, and this is found to be just as effective for many mental health conditions. We can also consider integrating mental health services in different places, such as the primary care behaviorist model, putting a behaviorist in when you go seek your primary care provider to lower the barrier to seek mental health services. Also training different community workers or paraprofessionals to aid in working with those with mental health conditions or those at risk of developing mental health conditions. Having mental well-being promoted in different community and school-based programs, and this can even be offered digitally to promote social interaction, physical activity, and mindfulness, all to improve mental well-being of the population. And finally, African American and Hispanic patients are more likely to quit mental health treatment at higher rates compared to whites, and they're harder to engage in treatment. So culturally sensitive mental health services are needed to engage and retain persons of color in mental health treatment. And that's it. Next. Thank you. If you have any questions, you can go ahead and email me.
Wonderful. Thank you so much, Veronica. We are just about out of time, but not quite. I just got a message from the tech team saying that we've got like 4 more minutes. I see we have one question in the chat that I can try to make it through. So let's see if we can do this. Jean Brenny says, these are such great presentations. Thank you. We did some similar work at SCSU in New Haven and Bridgeport. and are also now working on creating more equitable policies around safe housing and school-based support for students with special needs. My question is, what specific policy changes are you looking to see happen to eliminate these disparities? So I think this is probably a Deborah and team oriented question, but maybe for Megan. So.
Yeah, this is excellent. I can speak a little to this. So I believe that there are going, like, as the president of CPHA really elegantly pointed out during the intro to today's conference about focusing on equity. One thing that was really interesting, and like the next phase of our data analysis for the project that I did, is looking at, are there essentially micro social determinants of health. So I think trying, the first thing we need to do is figure out where these discrepancies are. And then from there, as we all talked about at the beginning of today's conference, like not only just acknowledging them, but then actually addressing them. One thing that came up repeatedly through some of the interactions that I had, just even anecdotally, were barriers, meaning like we have to make it easy for people to take care of themselves. And a lot of people who are living in today's society, they don't have the luxury of being able to go to the doctor when they need it. As like an example, or going to just even apply for housing in the first place, like that's a full-time job. Like, I mean, we literally have social workers, that is their full-time job, is to help other people do that. But when you're the person going through it and this is your everyday life, it is really hard, and everything requires an ID, and you need money and transportation, and you need places to be open, or you need a computer to get an ID. So I'd say if I had to pick one thing that we could do something about, I would say getting legal identification extremely easy and accessible would be like a huge first step in terms of like a policy suggestion that is like tangible. That would open up a lot of doors. That was probably the most needed thing out of everybody I spoke to. So that's my answer there.
I think to build on what Megan just said is the sort of larger issue of social determinants, right? I mean, I think everything that all of us just talked about was different sort of pieces of that and building on it, and that the pandemic only highlighted what, sort of what all of us in public health sort of already knew, right? So you talk to friends in other areas that were sort of shocked by things that we all just talked about and that we've been, studying and knowing about for years. And so I think, from the particular research that we did, I think system collaboration and building, sort of communication and connections that seem to have fall apart was a lot of what we saw that was just sort of shocking to us, that, how sort of were different pieces not working. And so basically what we found was that pantry managers were figuring it out on their own and just sort of creating sort of local community networks to sort of bridge that gap. But what we can do in terms of working together to build sort of better communication and networks so that we're better prepared to help create those, right? So just, sort of elaborating on what Megan just said, identifying where things, what are the key pieces to make systems work better, right? And some of this is work that's being done on community care teams and things like that, that sort of work together, right? So if you have, frequent flyers in the ED who are frequently being, that are homeless, that are being discharged to home, clearly that's not going to work, right? So what are the key pieces that they need? Well, they need a home, they need identification, they need a job, right? So these are the same things. They need access to food, right? The same thing that we were seeing in terms of what we were identifying with food pantries that couldn't figure out, how to provide healthy food. So we're just going to provide any kind of food, but then that's going to end up, the same people are going to end up in the ED because they're not, eating healthy food. So it's all sort of cycles of poor communication and poor systems. And so I think that that's where we sort of identified a lot of breakdown in systems. And so it's working together and creating collaborative systems. And that I wish I had the magic answer after 20 plus years in public health, but I think really looking at sort of how we can be more innovative with the dollars we have. And innovations like community care teams, where we really bring everyone together to the table, or collaborative networks like what we were trying to do in terms of food access, where we were bringing everyone together and saying, how can we have these conversations with everyone from the food pantry patrons and managers to, sort of federal level people that were providing the food to states, because clearly they weren't talking to each other. So what can we do, and how can we improve those systems? And hopefully those are some of the lessons learned for next steps.
Wonderful. Well, thanks to all of our presenters. Thank you everyone for being here. We are mere seconds away from getting kicked out of here. So I just want to say my final thank yous. And I will see everyone back in the main room very soon. If anyone has additional questions for any of the presenters today, we can certainly share those questions if you email CPHA. And with their permission, we can also share contact information for our presenters. And that is it. Thank you, everybody.